What does a pharmacist do? Well, most people might answer that a pharmacist dispenses the medications that my doctor prescribes. Now, I work with a ton of great pharmacists, and one thing that I don't generally see is excitement about pills in a vial. And this is probably because pharmacists have been trained to do so much more. So what can you get excited about in your community? To find out, let's go beyond the scripts. Hey, welcome back to Beyond the Scripts. I'm your host, Will Tuft, and today we are going to talk about a Pennsylvania mainstay. If you are in the Northeast at all, probably you've heard the name of Robert Maher, and you've also probably become familiar with a couple of the pharmacies in the area that he's involved with. So the Klingensmith's drugstore chain, and then as well as the Patent Pharmacy, a family pharmacy for many, many years. So welcome, Rob. Look forward to talking with you today.
Thank you for having me, Will. It's a pleasure to be here.
So for anybody who's not in the Pennsylvania area, who maybe hasn't gotten to meet you in person or seen you out on the trade show floor somewhere, tell me a little bit about your kind of career in pharmacy. Where'd you start and where are you at now?
Sure. I've been a pharmacist almost 30 years. It'll be 30 years this come spring. But I actually grew up in my father's family-owned pharmacy, which he started back in 1974. So at that age, I had been 4 years of age. But I probably fell in love with pharmacy when I was about 13, and we actually went from doing just good old-fashioned typewriter dispensing and had our very first computer. So so I've been working in the pharmacy realm, ever since I was that young. I ended up going to the University of Pittsburgh School of Pharmacy, and initially in my career, I thought I'd just be coming back home and working in the family pharmacy, which I did for a little bit, but I had the clinical bug, and I decided to go back after working 2 years and then got my post-PharmD. And I actually thought I was just going to be doing clinical inpatient, and I ended up doing a residency down in Durham in North Carolina in geriatrics at the Durham VA and the Duke Center for Aging. And it was probably there that I first got exposed of pharmacists could do something different besides, being in the distributor role, which is still very important. And we actually worked with physicians, nurses, and PT, OT, you name what, every healthcare professional who took care of a geriatric patient. And we were part of this team approach. And that was my first real exposure of how a pharmacist can really make a difference in terms of outcomes. And that's been 25 years. It's hard to believe, since my residency. And that has actually probably been my biggest driving goal, is to be able to replicate that type of model somewhere in practice. And I came back to Pittsburgh in 98 and got into teaching at Duquesne University, which is the other pharmacy school down the road. And I've been part of Duquesne for the last 25 years. But I started out doing inpatient. But what was funny, when I was inpatient, I was doing rounds, I found that everybody that kept coming to the hospital, and this was before penalization of hospital readmissions, they were frequent flyers. And they were frequent flyers because of drug-related problems, adherence, things that we still are dealing with today in 2022. And I kind of got frustrated because a lot of times I'd say at rounds, well, it's because of this. And they say, oh, the outside, they'll take care of that on the outside. Well, they never really always did. And they would come back in the hospital. And like I said, this is prior to hospitals being focusing on readmissions. So I ended up actually, my father and actually David Sipple, who I currently work for now, had started up a group of pharmacies in the Pittsburgh area in grocery stores called Hometown Pharmacies. And I actually started working with them. And just to make a long story short, over the years, those slowly evolved. And in fact, actually, Sean Nairn actually took some of those, and actually that's what Acor is kind of came out of those. And I had the opportunity a few years ago to come on board working with David Sipple at Klingensmith. And the Sipple family and my family have been friends for a long time, even I was a kid. And so it was kind of a natural fit to go there. And then I've also worked with my family's pharmacy, and we recently actually passed that on to another independent last fall. So My passion has been community pharmacy. And, one of the things, as I said to you earlier, is I still remember that model of when I was practicing in my residency of how could pharmacists do that? And,
Yeah.
that's where we are today. So that's kind of my short story.
So yeah, no, you took us on a long drive. So that drive down to Durham, when you were there, what did that environment look like? Were you like inpatient? Were you in a hospital? Were you in a facility most of the time? Or was it a pharmacy that was interacting with those entities?
No, at the time, it wasn't a pharmacy. It was actually, we were working in geriatric. We had two different versions. We had an outpatient geriatric clinic, and then we also had what's called the GEM team. And the VA system still has this. And actually, over the Center of Aging, they had something very similar. And basically, every discipline evaluated a patient. And these are patients that are teetering on the fence, that if the course doesn't alter, they're probably going to have to be institutionalized into a nursing home or personal care home. Hence, as we talk, one of the other new things that are coming up today, in pharmacy is the medical at home model. A lot of the things we were doing were very similar to what I think the medical at home model could do. But one of the things I remember when I was working in that residency, my preceptor at the time and residency director, Joseph Handlin, he actually had a little bit of an independent pharmacy background when he was in school. And, one of the things we realized is call the pharmacy, do a med rec. When somebody wasn't taking their meds, let's call the pharmacy and see how they're doing. And so we weren't working directly with a pharmacy then. And because it was a teaching environment and there was no reimbursement model, you had the best of both worlds in that the pharmacist had time to spend. All right. But, those principles that I got taught, those things are very applicable to today.
Yeah, it's funny when you take the money out of it, you can be really idealistic, but it's not very scalable.
No, it's not very scalable, and like I said, but the simple things still apply of identifying, what are they taking, what aren't they taking, why aren't they taking it, which can have multiple reasons. They don't like taking it, they have adverse effects, they can't afford the medication, or they're confused. They're on a lot of meds, and how do they keep track? And like I said, that experience I had in that year trajectory moved me on. And the other experiences is that, the one thing the VA system, does well is it actually utilizes pharmacists in that care model. And I got that both at Duke and at Durham. And also when I did some rotations at the VA here in Pittsburgh.
Yeah. Do you think that's just kind of a byproduct of, limited resources and really looking for, okay, we have these limited resources. Where can we best, get some bang for the buck? Who's talking to these patients? Can they also do this? Is it really kind of that frugal mentality of a stretched kind of service?
No, I think, and then sometimes it perplexes you that our own VA system, which is a government system, recognize that, what patients don't always need to see the physician. The physician, yes, is the head coach. I like to put that they identify what the problems are. But if somebody just needs, to evaluate how their insulin's doing, and we need to adjust the dose to get to their target hemoglobin A1C, or they're back when we use Coumadin a lot more, need to just get that Coumadin therapeutic. You're right that there's limited resources, and utilizing a pharmacist versus scheduling another appointment for that physician, and also the finances that go along with that, it was a perfect fit. And sometimes as we talk about provider status, we have a great model there to show that pharmacists could do this, and we are now starting to show that in the community level. So no, you're absolutely right. That's how that started.
Yeah, it's funny. We look at like so many retail pharmacies now are, I think, finally kind of getting on board with some of those efficiencies that facilities have to do things a certain way just by the nature of their structure. You can't give, 100 patients their medications willy-nilly throughout the day. You have to have everything very organized. You have to have their adherence schedule set up. You have to have a med sync cycle for the facility because you're not going to the pharmacy every day for all these different patients. So so many of those efficiencies that come out of facility management where you need to have a cycle. You need to have adherence packaging, dose packaging, Maher to, educate the rest of that patient's healthcare team. Bringing so many of those basic necessities in the LTC environment into the retail environment all of a sudden make a lot of sense and provide a lot of efficiencies.
Yeah, because I think an opportunity, and it's still a new topic in terms of reimbursement, is the medical at home model. There's a lot of organizations out there, and we have a couple in our area, like they are an organization that actually pays for care sitters. And these aren't really healthcare professionals. They're people trained to sit and take care of an elderly patient who couldn't stay it alone. However, because they're not trained, they're really not allowed to administer their medications. They can assist. But I talked to one caregiver one time. They were going to, 5 or 6 different pharmacies, getting pill bottles and thinking about, that's kind of, insane when you think about time wise versus, you're right. If you use a 28-day cycle, they're all synced at the exact same time each month, exactly when they're going to either be delivered or picked up. And so using that type of skills and then the other thing too, and I know that this gets said at the Pioneer conferences, it gets said everywhere, that, MedSync is that cornerstone to be able to do everything else. I always try to stress, and we're far from perfect at our pharmacies, and we're working there. But if I'm only at 25 or 30% synced, that means the rest of my day is, anywhere from 75 or 70% guessing. Whereas if we can sync and cross that 50% threshold, maybe to 60 or 70, then your day is a lot more manageable to be able to plan those things out.
Yeah. Yeah. And, it's not even only that, but also if you're looking at a patient's drug therapies like very sporadically throughout the month and moving drugs through, you're really not managing all of those alerts and warnings and the same way that you do with that appointment-based model. So much changes when you're looking at that patient's medication regimen as a whole, other than, let me get this refilled or on the way. So it's a much different kind of intentionality.
Yeah, I mean, that's one of the things that's happening here in Pennsylvania with our own pharmacy care network, is that we recently have gotten a new contract where they're willing to, have a reimbursement for adherence and for syncing. But one of the other things they're wanting us to do and willing to reimburse is med reconciliation and risk assessment. And when you think about it, if I'm onboarding anybody, and I still take this back to when I was doing my residency, is that first meeting with that patient or caregiver, that's when you want to do that full assessment. That's when you want to find out, what are they really taking? What aren't they really taking? And then that's the time to work with their doctor or their healthcare professionals to streamline that. And that could be a win-win for a lot of people, that, one, you're going to, maybe simplify their regimen, but two, especially if you're using some technology like, adherence packaging technology, whether it's the baggie system or multi-bubble, the more you can streamline it to the pharmacy, it could be a win-win for both the patient and the pharmacy, so that if somebody's on 15 medications, but they're taking a lot of things 4 or 5 times a day, whereas we could get them maybe to a drug once a day. Well, that's a win for them. And it also may be a win for us because, our technology is not having to overwork.
Yeah, we recently added a feature in PioneerRx called events. And basically this allows you to, record that interaction. So if you do have a new patient that came to you, something happened. So it may have been a routine flu shot and you've converted them into, a patient at your pharmacy, but it could be something like they went for their annual wellness visit, found out they have high blood pressure, and now they have this whole new, chronic disease state that is kind of weighing on their daily decisions there. And, it's a life-changing event. So being able to record that, or, if it's something much more complex, one of those patients that maybe just got moved to the area or just came out of the hospital, being able to record that event and have that history. But then, like you said, too, the med rec, which is also an area we have in the software, because that patient understanding and duplicate therapies, they come out of the hospital with all new medications, but they've still got the old ones sitting on their dresser at home. So many opportunities for that to create issues if you're not proactive.
Yeah, no, definitely. And that's one thing I also learned way back when in my residency. I got an opportunity to do, it was a month where I went out with a home care nurse, and we went out to all these different rural areas around the Durham, Raleigh area. And it was fascinating to see what was in people's homes. And it was fascinating to see some of the overusage and waste of certain medications. And that's a different topic for another time of should elderly patients even get 90 days supply just because of the waste and the complexity. And so that med wrecking is so important, I think. And I think that's something we as community pharmacists, can own, because we're that access point, that we're that, ability to help those people.
Yeah. I mean, so often when we have these podcasts, or if you go to any of the trade shows, the conversations steer to, some of those primary care opportunities that pharmacists can fill. And that's certainly true. But I feel like this is one of those spaces that is directly in independent pharmacy's wheelhouse and so often overlooked. Is just taking that little bit of extra time, especially on a new patient intake or, an existing patient that, hey, you just got out of the hospital. Let's talk about that.
Yeah, no, absolutely. Or, something simple we do that when we first started adopting the MedSync process of Pioneer, every patient, and this is regardless of their adherence packaging, gets a pickup report. And we print that pickup report, and it actually says when their next sync is. And what we try to do is to train our fill clerks who are, our cashiers at the register, that if somebody comes in to pick up that med sync and that date of that pickup date is really off from when they should have, all right, that, they're 5 days overdue, or they're, obviously we're putting things back, if it's, more than 10 days or 14 days, but that's a talking point. Why are you so off? And a lot of times we don't even know that they were hospitalized. Maybe they were, because that's probably where we need to get better is how can we, partner with our hospitals in the area, our physicians in the area to find out when those things are occurring, because you're right. That's the next time where somebody's taking something that they shouldn't be taking, anymore, and they didn't even realize they were supposed to stop it.
Yeah. Yeah. And that 5-day thing, that's probably not that the patient went a whole business week without taking that medication. It's probably throughout that 30-day time period or 28-day time period, they missed 1 day every week, and what's no big deal, right? But yeah, great coaching opportunity. So you mentioned the PPCN. Tell me a little bit about that and how that kind of fits in with CPESN and your local.
So here in Pennsylvania, and this is something, I actually very proud of, that we've actually have had a very strong leadership in terms of our state pharmacy association and our members. And, I'm losing track. It's probably beyond more than 10 years, but almost right when the CPSN was starting to form, and, Joe Moose and all of them were doing what they were doing in North Carolina, we actually were working on the same thing here in Pennsylvania. And we were actually, the first thing I know that got created, there was a grant that it was with the University of Pittsburgh and PPA, were just training pharmacists how to do MTM. And then out of that, started talking about creating this pharmacy care network. And it slowly evolved. We created our own training program. So one of the things to belong to the PPCN, every pharmacist has to be trained, and myself and multiple colleagues, both who work in community pharmacies, who work in academia, all 7 schools of pharmacy. We have 7 schools here Pennsylvania, it's hard to believe, but all 7 schools contributed to that. And then just recently, myself and Nicole Pizzino from Wilkes University, we revamped that training. And the reason why we have the training program initially for our pharmacy care network is when we go to a payer, we say that our pharmacists are trained to be able to take care of patients in multiple different ways, like we've just been talking about. And so that goes a long way, because I can remember when I came out of my residency and I was here I was here at Duquesne, and I met one of the bigger payers in our area, and I'm talking to a guy who's a pharmacist, and I said, you know what? I know and this was actually about asthma at the time. I said, I know pharmacists could do a great job and improve outcomes for asthma. And he flat shut me down and said, it'll never work. And I said, why? He goes, because how do I know the Rite Aid down the street and Joe's Pharmacy down the street are doing the same thing? And I think that's one thing MTM, even though it was slow in starting, did was it created that pharmacy care process. And so our PPCN kind of originated out of all those things. And we actually have, currently right now we have, I'm trying to think, we have about 3 or 4 payer contracts going on right now. We've actually had a payer contract probably over the last 5 years in some form or another. And our leadership in the PPCN, we do weekly meetings, we have luminaries. And so we're probably a little bit stronger more in the western part. We're trying to get better contracts in the eastern part. They recently realigned our Medicaid managed care, but it is alive and well. And payers are starting to notice, and that that pharmacists do make a difference. And so we've got a great opportunity. And one of the things I always say is this opportunity is here, but it could go away really quickly if we don't take advantage of it and show what our worth is. So that's, like I said, I never thought we'd come to this day, but I also know that we got to treat this day very special and do our darndest and work hard to be able to accomplish that.
Yeah, that was one of the big themes that they talked about in the Catalyst podcast recently with Doug Hoy, where they're talking about making independent pharmacy easy to work with, and having some of those, technology bridges that put those independent pharmacies in a playing field that they can work together and say, yeah, we can perform these services. And it's so interesting because throughout healthcare, like it seems like everybody's looking for somebody that can help them with, improving the metrics, improving performance, getting the, getting the patients to, stay out of the hospital. And pharmacies independent pharmacies specifically are uniquely positioned to do that. So did that kind of start before Klingensmith's or while you were there? Because it seems like you were in kind of a unique position where you already had a bit of network adequacy for a large geographical area with that pharmacy.
Yeah, we actually, when I first came on to Klingensmith's full time, and that was back in 2015, our first program that I started was we had a transition of care program, and it's kind of cooled down because of COVID and just access to the hospital. But we had a program where we had patients get referred to us, we delivered the meds to their bedside, and we did a 48-hour call, to evaluate them. Unfortunately, we weren't getting reimbursed for that clinical side. We were only getting, making, some revenue on the distribution side. But it started that partnership with our local hospital. The one thing, the Pittsburgh area, we really have 2 major health systems, and over the last 25 years, those health systems pretty much have bought up the majority of the local hospitals, and they're part of their network. But I'll give that where we're located about 40 minutes north of Pittsburgh, our hospital still stands independent. And so we've worked with them. Prior for me coming, they had already had a relationship with the 340B. But yeah, we do have a very good relationship with them. Actually, we held joint clinics during COVID. In fact, I go up and give shots at the hospital for people that need COVID shots because the hospital's not in the business anymore, just due to staffing and things. So we do that. So, we already had that there. before we even had our first payer contract.
Yeah. So early on, you know, I think most payers could see the value if you can communicate that you have, an organized delivery method, for that care. So how did you quantify that? Because that was before e-care plans were really available. So how did you pitch that you would quantify it, and then how were you able to actually produce that?
Well, the one thing that were able to do is we had a full-time technician that actually helped drive the program, and she had a lot of experience in healthcare. So she was our eyes and ears up at the hospital and worked directly with we used our pharmacy that was the closest to the hospital. And prior to 2019, we didn't have Pioneer, and our system really couldn't track anything at the time. However, we got unique with it. And we did actually at the time use an Access database file maker to help keep track that would interface with our system. And so I did track, I tracked, how many calls we made for people post 48 hours, how many times we identified possible problems post 48 hours, how many readmissions, because we were able to get the readmission list. So we tracked how many that we took care of, because obviously we didn't take care of every patient. So we did track those things for the hospital. And I'm happy to say in the time period we did it, we were way below 5% in readmissions. We also,
oh, wow.
and I have two good stories that came out of that. We had one patient who actually, this patient was a patient that was a frequent flyer to the hospital. And a lot had to do was her one doctor had dropped her because she couldn't make her appointments, but a lot of it was a transportation issue. She just couldn't get that. The other thing was, she was using various pharmacies. And so we were able to get her med synced. We were able to get her, adherence packaging, and we also delivered to her. And, that kept her out of the hospital. Another one we caught that was actually kind of glaring, where a patient got admitted to the hospital, was not with it, and they accidentally took his medicine list from his wallet. Didn't accidentally. They found his medicine list on him, but when they put him on those medicines, when we were doing the med rec, actually they were the medicines he had been on 3 years prior.
Oh, wow.
And so, and it was because there was a good chunk of those patients who were already our patients, because we have 7 stores and 2 are in Clarion County, 5 are in Armstrong County. And so I think there's only 13 pharmacies in Armstrong County. So we have a chunk of them. So when we would do the med recs, we would also med rec against our own system. We identified that and, worked with the doctors to be able to do that. We also worked with the doctors when people couldn't afford their meds. And, how many people did we have provide access? So we kept track of not only readmissions, but how many interactions, how much access. And then internally, we kept track of, from a business standpoint, how many prescriptions did we fill? How many of these patients did we retain? Things like that to try to prove, justification for it.
Yeah. So then how did that relationship work early on with the payers? Was that a annual bonus, or like a membership kind of fee?
Well, this one we never got paid. We never got paid because this was our own program. All right. But the original programs that we had with the PPCN, pretty much all of them have been Medicaid managed cares. Actually,
Yeah.
And one of them was a Medicare low assistance CMR program. And so those ones right now it's still kind of a fee for service. They're tracking outcomes. But, the first contract we ever had was, could we access the patients? That was the first contract we ever had. Because
Wow.
if you think of one thing about Pennsylvania, if you look at the state, everybody thinks about Pittsburgh and Philadelphia, but when you look at our state, it's a pretty rural state. There's a lot of rural in Pennsylvania. And the one thing that, these payers, Pittsburgh is a 412 area code. And if I'm in a 724 area code and with caller ID, getting access to these patients just isn't realistic. And so one of the things we showed was we could see these patients. And actually, that first contract is what built us to this new contract we have. And the other thing I found, well, not just myself, but I can't take credit all for it, but our leaders in the PPCN is they started working with the case managers in these programs, and realizing our access. And so one of the things we're this new model we're getting reimbursed for is to do social determinants of health evaluation and health risk assessment evaluations, and then identifying if these problems patients do need referrals, getting them to those caseworkers, on their behalf. So realizing that we are that access point. So like I said, it's evolved over time. I think the one thing we learned with our transition of care program was, one, our technology was lacking, and two, we were able to develop a workflow. And I think that's one thing that, I do, this is not a plug, but what I do love about our system now is the ability to develop workflows within our system and the ability to track things within our system to be able to deliver these programs.
Yeah. So, I mean, that's still the state with a lot of pharmacies now, is that, it sounds like that was a heavy lift, but a necessary lift to be able to show the proof that, yes, we can affect change. Here's the spreadsheets we built and can show that lower readmission rate. So it's no longer a theoretical conversation. You're having a much different conversation when you do go to the next payer.
Yeah, and then even in that early program, because like I said, our tools were a little rudimentary. We developed ways that if I had to do a 48-hour phone call, how did I know what patients I needed to call? And then two, one of the things that, because we had developed this relationship with a hospital and we had a HIPAA business associate, we had a contract, we got access, and they were paper access. So we actually had scanned documents of the discharge summary, their most recent labs, so that when we made that phone call, we have access. And I think that's the biggest next step, is to be able to interface with providers down the road so that I could have access to labs. I could have access, because, one thing I've taught students, I've taught pharmacists, that you give me their med list, give me their problem list, give me their most recent labs. And when I say problem list, their diagnosis, and then let me do my med rec, give me the most recent labs, and I can go to town. All right. I can truly do a real evaluation. I just need that data. And that's probably the next step for us to really push these programs, is developing those partnerships so we can have access to that data. And sometimes you don't realize. I was doing a diabetes education a couple years ago for a new patient, a young patient who had suffered a mild heart attack. She was only in her 30s, and she had really bad diabetes. She was obese. And I started talking to her, and I said, well, do you know your labs? And she whips out her smartphone, logs in, and boom, she shows me her labs. And we were ready to go to town, to do that. So so figuring out ways to do that, I think is going to help us grow too. Sorry, I probably went off on a tangent there.
No. I was just thinking, so many of those tools exist now, and PioneerRx, and those are based on those conversations. Exactly. So having access to MedRec in the system, labs in the system, but getting that data and populating that data, pharmacists, always find creative ways to do that. And I was thinking back during COVID, when there's all of a sudden this brand new need to, process thousands of immunizations very rapidly. And, some of the ways that pharmacists came up with using jot forms and, so many different web scheduling solutions and finding the ones that work, and then sharing those solutions vocally with other pharmacists.
That reminded me of another COVID story we did, and this was utilizing, our technology. Was we had, when COVID first hit and we were locked down, we realized there's a bunch of patients we don't have synced. And there's a bunch of patients, how are they going to have access? And also worrying about shortage of staffs, how are we going to be able to handle that? So we actually created, high risk categories in Pioneer based on who was high risk of getting COVID. And we basically created those categories and then ran reports of who's in this category and who's not synced. And then we actually worked with students, both at Duquesne and University of Pittsburgh, and we got them to help us make those calls. And we know obviously they all signed HIPAA and things like that, but we used actually doximity so that when they were making calls, it was coming from our pharmacy. And within a 3-day period, we got 60 people across our stores signed up for sync. And
Wow.
I would have never been able to do that type of lift 10 years ago in getting that. And like I said, that was that took a lot of people to do that, but to be able just to identify those patients, it was the first step.
Yeah, that's one of the fun things I like playing in the software with, seeing if I can like come up with, a new way to, generate a really helpful subset of patients given the new release that came out this week. So
yeah, and I guess that's probably some of my joys and fun too, that I told you I grew up with the first computer system. In fact, I learned it quicker than anybody at age 13. In fact, actually, that's how far back David Sipple, the owner, and I go back. He used to work at our store every Tuesday when he was just out of pharmacy school, and I was his tech at 15 years old, helping him, fill the prescriptions. But I always loved computer programming, and I never went on to become a computer programmer. But sometimes when you're figuring out categories or figuring out, some of the new things with our e-care plan systems and just the workflows in general, that falls right into that realm of computer programming, and it actually makes it fun when you think about it.
Oh yeah. Yeah. When you can kind of apply that clinical logic, those word problems that you're currently working every day in the pharmacy, looking for those at-risk patients, for example, and then, what switches can I flip to narrow those results down? It's always kind of fun.
And you're right. Templates was probably the greatest thing when that came out.
Gosh, yeah. We worked with so many great pharmacists who were like telling us, "Hey, look, this is what we need. This is what we need. This is what we need. Here's how we're doing it." I know, Mark Ost and Ren Ching and Scott Pace up in Arkansas. I know we had people all over the country that were really instrumental in giving that feedback in real time. Because that heavy lift, like I said 10 years ago, or when all of a sudden you're in the same position because the landscape totally changes with the new pandemic.
Yep. And that's one thing I will also say about our state network is, in my lifetime, I've never seen pharmacists come together as well as they have working together. And, we just had our State Pharmacy Association meeting last weekend, and just that we're willing to share ideas. We're willing to figure out, what are best practices. Stephanie McGrath, our executive director, about almost every Wednesday, we have what's called Coffee and Conversation. And one of the members, it doesn't necessarily have to be using Pioneer, but one of the members shares a new workflow or something that they're doing to help grow these, different programs. And so I think that's a testament to, I think that's the new wave of independent pharmacies. I mean, I can still remember growing up that, the independent pharmacies sometimes looked at each other as the competition, and we no longer can look at that way. We're together as one. And you were mentioning Doug at NCPA, and I think Troy Triggerstead at CPSN says is that the one thing the network does do, both at the national level and the state level, is now payers know when we need something solved, how can we get all these people together? Well, they go to the network leaders, and then the network leaders can, get that out to all the members. So that's one thing that's really helped, immensely over the last couple of years.
Yeah, absolutely. And I think, independent pharmacy as a whole, kind of even beyond any of the leadership groups and industry groups, but just independent pharmacies have really shined through COVID. And now that that's kind of winding down, there's so much goodwill and so much, equity built into the communities from that pandemic. How do you think that rolls out to the next thing where, you know, life goes on. All the payers are still looking to, save money and get the most value for their plans and for their community. So, what do you think's next?
Well, I think that's just, there's the old saying that I think it was John Rockefeller once said, success is doing the common things uncommonly well. And, I think, fine tuning ourselves, with, our MedSync programs, with our adherence packaging, with immunizations themselves. I mean, just think about, COVID, but how many people, think about COPD patients. I was just giving flu shots yesterday, and I was listening to this gentleman wheezing the whole time. And I asked him, I said, you have a pneumonia? Have you had a pneumonia vaccine? Which he did. But those opportunities that, you're right. We have this goodwill, and we shouldn't rest on our laurels on it, that we should be, moving the needle of, how can we do that? And what's great is that, we've made some great partnerships, not just with physicians, but, our different community leaders, organizations, our immunization, like yesterday I did a clinic and I did, 30 flu shots, and I also did almost 30 COVID bivalent vaccines, at the same time. And that's the other thing. If you would have asked me, 15 years ago when I first started doing shots, could I do more than 6 a day? And I'd say, oh no, I could never do more than 6 a day. You find it creative of what you can do. And we just have to keep becoming innovative and working together to get there. And that's what the other thing that's exciting. And this is me putting on my teacher hat is that a lot of our young pharmacists, they're not sure about community pharmacy, because there's another side of community pharmacy, because of the way reimbursements are and everything, that there is an ugly side to it. But I keep telling them they're the future, and they got to speak up. They got to say, I don't want to practice that way. And these type of networks, this type of growth is probably going to get us there. Well, it has to get us there. I don't think we have a choice. I think if you want to be in business in the next 10 to 20 years, you've got to be creative of what you do. And you've got to be more than just an access point for medications. You're an access point for, somebody used this term a couple months ago. We're not always the drug experts, but we're the experts of optimizing medication therapy. And that has, when you think about that term can mean so many different things, getting somebody, truly adherent, identifying a drug therapy problem, identifying that they need immunization or they're missing a medication. They're on Fosamax for osteoporosis, and, ask them, something simple. Do they take a calcium supplement so that they can keep their, from their bone loss, from getting worse? So, there's things that we've been doing, Will, for the last, 20, 25 years that we took for granted. And I think we have to capitalize on those things that we do well, because it still matters. Unfortunately, I always say we're not, unless something miraculously happens, we don't cure diseases, really. We cure some infections, we cure cancers, not enough. But what do we do with our medications? We use them to slow the progression of the disease, prevention of a disease, treating of symptoms. And if we optimize those medications well enough, we can't keep people out of the hospital and the ERs, or we can keep people living at home, not having to be institutionalized and be part of their community. And so I think that's the next step, just to keep working on those common things we do.
Yeah, I think that last topic especially is something we haven't really visited often on this podcast, but it's such a huge slice of the healthcare spend, and socially such a scary and difficult and expensive and, estate wrecking expense. But that geriatric care and facility management, like if you can keep somebody adherent, if you can keep somebody, on track and managing their disease states, if not defeating them, but at least, staying home and aging and their community, there's such a huge need for that on a healthcare spend, on a social spend, on a heartstrings pull, that in all of those areas that really I don't see that anyone but independent pharmacy can fill that. And so how do you think that independent pharmacies can, really convey that value? Are there metrics or opportunities there?
I think that's the next frontier. I mean, I think that whole realm of the medical at home, and we're trying to figure out how to, justify so we can get paid to cover those services. That because we're doing kind of the same services as we do in long-term care. However, I think the best places to go out and partner is with home health agencies, all right, that are trying to do the same thing, keep these people at home. Even group homes and personal care homes, which they're a lot of times based in that person's community. They can only take care of people if they can at least do the basic things. And if you can help identify. So, for example, one of the things, and I know that we don't do this yet at Klingensmith, but in putting on my old geriatric hat is fall risk assessment. There are many medications can lead to falls. There's much data out there. If you're on 2 or more CNS type of drugs that cross the blood-brain barrier and get into your brain, you're at higher risk for fall. Somebody breaks their hip, all right, their life expectancy may be less than 5 years based on some of the data out there. So just identifying falls to be able to, the other thing is marketing it to caregivers such as family members. I had a great grandfather who lived 6 months shy of 100, and I had my other grandfather, pass away in his early 90s, and both of them lived at home pretty much until the end of their life. And my great grandfather slipped and fell, all right, and broke his hip, and kind of the trajectory of his last year and a half was, having to go to a home. And my grandfather hurt his back, but for a long time, they were able to stay at home because they had caregivers. They had somebody managing their medications and being able to do that. So, a son or daughter, if mom and dad lives in the same town with them or whatever, they would rather be able to go visit them at their house than, having to go to a nursing home, which that's not always the greatest environment to go visit a loved one. And sometimes they're isolated, things like that. So, I think doing that med rec, there's lots of programs. You don't have to go do a geriatric residency to be a geriatric whiz, but there's lots of programs of, identifying, there's, the Beers criteria, the stop criteria. They're not perfect, but they guide you of what are bad drugs that elderly people shouldn't be on. What are things that put them at risk for falls? Just getting them adherent. I think those things we could do well because we have that access point, for that. So, I speak passionately about it, but I know we could. And I know that from experience from what I've done in my residency, what I've done in geriatrics. And I always tell a story, and I did a CE at our state association on the medical at home, because I think this is the next realm. And for the medical at home is what we were talking about earlier. You bring somebody on board, you do a good med rec, you look at their medication regimen, you simplify it. Ask the simple questions. Have you fallen in the last couple of weeks? When you fell, did you break anything in the last year? Do you get dizzy when you sit up? And then just look at their meds. And, there's enough software out there you can identify. But when I worked with the hometowns, we had a pharmacy resident. And this pharmacy resident, was working with this lady that was down the street, and she had some early dementia, but she could take care of herself. And we actually simplified her regimen. And we didn't have fancy adherence packaging then, but we actually had 7-day, pill containers. And we simplified it to morning and evening. And she and her daughter, who lived in California, kept wanting her to go to California, and she didn't want to. She wanted to live in her community. She went to her local church every day. She went to the senior center. And by doing that adherence packaging, she stayed there for about 3 years. I don't have true scientific evidence that was it, but the community and her neighbor looked after her.
Yeah.
3 years later, she had to go to the she ended up flying out and living with her daughter. And I can remember this same resident actually worked for us, and she said, you know what, I guess maybe we failed. I said, no, we didn't fail. She got to live 3 years of good quality of life the way she wanted to live. And I think that's something that, all community independent pharmacists take pride in their communities. And I think that's something that's the next big area to do. And, the tools we have to be able to just putting in, putting people in adherence patching facility, med syncing, they're all there for us to be able to take advantage of this.
Yeah. And, you mentioned earlier the social determinants of health and, just being aware of that patient's situation, like you said, is such a big thing. If you have an elderly community in a rural area, there's a good chance they've been in that house for 50 years and don't want to leave, which could explain why that step is broken on the front porch. Those little social determinants, those risks that, Joe Williams was on one of our earlier episodes, and he talked about a delivery driver who showed up and couldn't get in because there's a tree branch that had kind of fallen down. So, they show up with a chainsaw and they take care of that for the patient, and obviously in some communities you have that ability to do that. Of course, I don't know how you bill for, your time with the chainsaw, but being aware of those patients' challenges is so important.
Yeah, and that's actually, I think that's an important thing when you're talking to payer contracts. One of the things with our current payer contract is there's an opportunity for home visits, and it may not necessarily have to be a pharmacist. It could be, a trained, driver. You hear Trip Logan talk about the community health worker.
Mm-hmm.
So having those, I think that, that's the future, because, that unfortunately there's social workers are probably one of the most important parts that we're on our geriatric teams. The problem is that they're so important, but we don't pay them well enough, and there's just not enough of them because of that. But there's a lot of people that do social work type of tasks that could help with that.
Yeah. It's, really being able to demonstrate that value and have those resources available that are sustainable. Of course, you would love as a pharmacist, as a business owner, to personally go out to every one of those houses and, rake their leaves for them and do everything you can. Obviously, it's not very sustainable. So always interesting to see how you can, come up with ideas to convey that value. So with CPESN in Pennsylvania, do you have any exciting new contracts underway, or what are you guys doing locally? I know you're involved with CPESN there.
Well, I think the most recent one, like I said, it's an array of services. It is the ability to get paid for MedSync, adherence packaging, home delivery, naloxone counseling. So this is the first time we have multiple things in MedRec, multiple things in one payer contract, almost like having provider status. These are things we do every day, and so that's probably our biggest one. We do have an asthma COPD program, which actually that was one that, because one of the things too, what I like about our system now is the ability to have reports that are customized, that they can be customizable to patients. And that actually helps out, because a lot of times, you can train technicians and clerks to help with that. So getting to your question, I think the more we work on chronic disease states that we can help out with these health plans, helping with, the underlying problem that leads people to hospitalization in the ER is, not taking their medications. That's kind of where we are. So that's our biggest niche. Where we at Klingensmith is what we've been talking about, is we really want to grow that medical at home model. We have the packaging tools right now. I truly believe that with, leadership at NCPA and, people talking to CMS, that there's going to be a reimbursement model for this medical at home model that is viable. They already came out last December and said, yes, we believe this is true. But that's our next step. Our next step is to take care of those people in our community. To do that, do we have challenges? Yes. Non-preferred contracts, things like that on that distribution side. But, the one thing that hopefully everybody's learned, that the health benefit payer is a whole lot a whole lot different than that other payer that begins with that has the abbreviations of 3 letters, so that's
Yeah.
where that's where we're focused on, and we have to take advantage of it. Yeah, we still have to worry about product reimbursement, but we have to keep figuring out how to make this work and to make it work in workflow, because probably our biggest challenge is because there's not enough of this revenue yet. We can't make a model in our stores to support that completely. We're still heavily dependent on that product, but we need to start figuring out how to treat this on the sales report, just like we do, prescriptions. And how can we staff that? How can we, identify ancillary staff, good trained staff, technicians, community health workers to help support our pharmacists to do that. So.
Yeah, and when you start to stitch all of those together, I had to pull up. That was the new Highmark care goals in Pennsylvania. Yeah, I couldn't think of the name. I had to pull it up real quick with CPES in. But yeah, looking at those naloxone, MedRec, social determinants, all that stuff you're talking about. But again, stitching that together with those enhanced services for delivery, with getting a MedSync program, with reaching out and increasing prescription volume by getting those extra fills. Sure, even if reimbursements aren't ideal, increasing that volume, making those other product offerings, being able to, maybe extend OTC and immunization sales based on those processes. So, it's not always that you're going to immediately get paid by another payer, but it sounds like you've certainly put in a lot of work to prove that value.
Well, the last thing I'll say with that, I think, is important, and maybe we didn't realize this at first, but we're starting to realize it, that, yeah, this payer is going to pay us for MedRec, MedSync. Well, you know what? Let's make our workflow that we do this with every patient we MedSync. We do a MedRec. And maybe we also throw that risk assessment in there too, so that it becomes the standard, and that's what we do. And so that when a new payer comes up, just like I told you that story of that payer say, oh, we'll never pay that pharmacy because they all don't do the same thing. If it becomes the standard of what we do, that's what our workflow is. That's what we do. It's not something extra, because when you do it extra, it can get ignored when the times get tough, right? And you just go back doing what you like. So that's what we're trying. Are we perfect at it? No. But this payer program, my goal is that it becomes our standard, and that's what and one of the things that you have to, whether it's Pioneer or whatever your technology solution is, you have to figure out, what can I automate to the max so it can help me, do what I need to do most, and that's spending the time with the patient and identifying what's wrong or educating them and taking care of them.
Nice. No magic bullet or secret program, just good old fashioned being great at being a community pharmacist and documenting it.
Yeah, I'm a sports nut, and I'm growing up in Western Pennsylvania. But my biggest passion, I love basketball, and I can still remember our coach, making us do dribbling drills or simple defensive slides that had nothing to do about shooting. And he always told us, if you can do all those things well, come game time, you'll be ready. And that's what we have to do with these services. Do them well, and make them part of what we do.
Yeah, that's and make sure that you're documenting and telling it, because even if you go to the gym and get a great workout, but you didn't post it on Facebook, did you even go?
Yeah. I think that's probably the biggest challenge is we can create the care plan, but the care plan also has an important section in there called notes, so that we need to also remember to put in the notes section the stories that we did, so that when we are trying to show payers what have we done, not just those biometrics, or adherence metrics, but we can also tell the stories of what we need to do. So I think that's the other one, is figuring out how to document that too.
Yeah. It's, it takes a little bit of additional time, but it's so important that, if you don't document it, it didn't happen 6 months from now. So, is it more work. I mean, no, it's just crucial that you show what you've done. So we're creeping up on time. I'm going to let you get back to work. Thanks so much for joining us. I want to check in soon and see what new programs you have coming and what you guys are up to, because it sounds like you guys have a lot. And I had like 3 other topics to touch on and didn't even make to them.
Get on different tangents there, but
No, it was good. It was. I would have steered you back over if.
okay. Okay.
All right. Well, thanks for joining, and can't wait to see you soon.
All right. Take care, Will. Thank you. Bye.
Thank you for listening to this episode of Beyond the Scripts, presented by the Catalyst Pharmacy Podcast. If you enjoyed this episode, please support our channel by liking, subscribing, and clicking the notification bell so that you'll be notified anytime we post new content. To stay up to date with all of the latest independent pharmacy news and content, follow PioneerRx on your preferred social media platform.